أهلا بيكم. Today we're going to continue our talk about the orbit and eye. So let's start. Now we've studied the walls of the orbit and the fascia involved in the orbit, and we will start with the muscles. You can classify the muscles of the orbit as extrinsic and intrinsic. Extrinsic means they are the ones that control the eyelids and the movement of the eyeballs. And intrinsic means the inside muscle, inside the globe, that control the shape of the pupil, like the constrictor pupillae muscle, like the dilator pupillae muscle in the iris, like the ciliary muscle that controls the size of the lens in the accommodation reflex. Okay, so we'll start with the extrinsic muscles. The extrinsic muscles, we have the levator palpebrae superioris muscle, 4 recti. We have 2 obliques, superior and inferior oblique, and orbitalis. And the movements they produce on the globe are elevation, depression, adduction towards the midline, abduction away from the midline in the horizontal, and internal rotation and external rotation. Internal rotation, external rotation. These are the movements occurring at the eyeball. Another thing we will talk about is the axis of the orbit in comparison to the eyeball. The eyeball, when looking forward, the axis is longitudinal, anteroposterior, and points forwards. But the axis of the orbit is medial to that axis, means it's in the posteromedial direction or anterolateral direction. Okay, so they have an angle with the axis of the eye, and we will talk about this when we want to test the muscles. But remember this, we're not talking about the equator of the globe, we're talking about the anteroposterior or longitudinal axis of the eye. Let's start with the levator palpebrae superioris muscle. This is the levator palpebrae superioris. It's the most superior muscle, the highest muscle in the orbit. The first thing you see after you extract or remove the bony orbit, the roof of the orbit. And it comes from the posterior part of the roof and fans anteriorly to form an aponeurosis, to be attached to the anterior surface of the superior tarsus. Remember the superior tarsus, the tarsal plate in the upper eyelid, on the anterior surface of the superior tarsus. Now, also do not forget the relation with the lacrimal gland. The lacrimal gland is in the superolateral area of the orbit, and it curves around the lateral edge of the aponeurosis of the levator palpebrae superioris, and even both parts of the gland are connected by ductules through the aponeurosis of the levator palpebrae superioris muscle. Do not forget this this relation with the lacrimal gland. Okay, now one more thing about this muscle unique is that the ventral aspect, the inferior surface of the muscle, has a special layer of smooth muscle layer called the superior tarsal muscle. Now, since it's smooth muscle fibers, so it's supplied by autonomic, sympathetic supply. So this muscle will have dual nerve supply, one from the oculomotor nerve, the nerve of the orbit and or the extraocular muscles, and the other is from the sympathetic supply to this ventral aspect, which is the superior tarsal muscle. The superior tarsal muscle originates like the levator palpebrae superioris, but inserts at the edge of the tarsal plate, not the anterior surface, at the edge of the tarsal plate. Okay. Other muscles we mentioned are the recti. We have superior, inferior rectus. We have superior, inferior rectus. We have lateral and medial rectus. How did I know that this is the lateral rectus? Because the tendon of the inferior oblique is underneath. It goes under the lateral rectus muscle. Okay, so we have lateral and medial recti, superior and inferior recti. Note that the superior oblique, the superior rectus is not the most superior muscle. See, on top of it, there is the levator palpebrae superioris. This is another, angle. This is the superior oblique, the superior rectus muscle, while the levator palpebrae superioris is reflected. Now they all arise from a common tendinous origin formed by the periorbita. Remember when we talked about the periorbita? We mentioned that it forms a ring, fibrous tissue ring that will act as a common origin for extraocular muscles, right, like the recti muscles. See. And they all fan into a cone of muscles that will be attached to the anterior part of the eyeball. Anterior means anterior to the equator. Now, doctors, if they are inserted and they are coming from the posterior aspect and inserted behind the equator, the only action will be exerted on the eye is pull backwards. But since they pass the center of the globe and insert anterior to the equator, this will get rotational movement in the form of elevation, depression, and side-to-side movements. Okay? Understand this, please. Because the muscles, all the muscles are coming from the posterior aspect. So they will insert in front of equator, except, for example, this muscle, the inferior oblique, which comes from the front and goes backwards, so it must cross the equator and inserts behind the equator of the eye. And I repeat again, the equator is not the axis I'm talking about. The axis of the eye we will be talking about is the anteroposterior one, not the equator one. Now, for the actions of the recti, see, they come from posteromedial aspect. So expect the superior rectus to elevate and adducts as well, because it's coming from the medial side, and will intort the eye. The superior rectus will intort, internal rotation of the eye, which is internal rotation, which is anti-clockwise, okay? The inferior rectus will bring the eye down, adduct as well, but will externally rotate the eye. External rotation means clockwise, external rotation of the eye. Okay? Of course, clockwise and anti-clockwise if you're looking from posterior aspect, not from anterior aspect, okay? You know what I mean by internal rotation and external rotation. The medial recti, medial rectus and lateral rectus, they just, the medial rectus adduct the eye, the globe, and the lateral rectus abducts the eye. Now, the nerve supply of all will be the oculomotor, the superior rectus by the superior division, the rest of recti by the inferior division, except for the lateral rectus. See, the lateral rectus receives its own nerve, which is the abducent nerve, the cranial nerve number 6. It goes for this individual only muscle, which is the lateral rectus. This is the abducent nerve supplying the muscle. And see the superior division of oculomotor supplying levator palpebrae superioris as well as the superior rectus, and the inferior branch is supplying the rest. This is not the inferior branch. This is the nasociliary nerve branch of ophthalmic we'll be talking about. Okay, so this is about the action of the recti. What else do we have? We have the obliques, the superior oblique and inferior oblique muscle. Now look for at the superior oblique. Arises from above the ring in the roof of the orbit, and it's on the medial side and goes, and it's the most superficial on the medial side, means that it's above the medial rectus. It's the one showing high up. Then there's a trochlea waiting at the front of the orbit. The tendon of the muscle will turn backwards and posterior lateral. See? So it must go behind the equator of the eye, because now we'll consider the muscle runs in this direction. Forget about this part of the muscle, because this is the part that exerts the action on the eyeball. So we will be talking, if we are talking about the axis of the superior oblique, it will be this axis of the reflected fibers, not from the fleshy muscle fibers. You got it? Because this is the part that will exert its action on the globe in this direction. You know what I mean? Okay. So it's reflected and goes back behind the equator in the upper lateral quadrant of the eye. If you pull on the muscle, the eye will be pulled down, means depression, outwards means abduction, okay? And internally rotated, intorted. This is the action of the superior oblique. It brings the eye depression, abduction, and internal rotation, okay? The inferior oblique has a different story. It's the only muscle, I showed it to you in the last slide. It comes from the front and goes under the eyeball, under the inferior rectus, parallel to the reflected part of the superior oblique, posterior and lateral, to be inserted deep to the lateral rectus on the posterolateral quadrant of the posterolateral inferior quadrant of the eyeball here, under the lateral rectus, okay? All these points are important for multiple choice questions. You will encounter many questions regarding all the points we are mentioning here. Okay, so please concentrate with this. It comes from the front and inserts deep to the lateral rectus on the posterior inferior lateral quadrant of the globe. With the direction of the muscle, it will bring the eye up, elevates the eye, abducts the eye, but externally rotates the eye, extorts the eye, okay? The superior oblique will intort the eye, while the inferior oblique will extort the eye, okay? So these are the oblique muscles. One more muscle left is the orbitalis muscle, a muscle that's totally on the floor of the floor and sidewall of the orbit, bridges the inferior orbital fissure, and supplied by sympathetic. So it's thought to be a muscle that supports the globe and keep it, at front. And the proof for that is in Horner syndrome, the patient will get a sunken eye. So the orbitalis is paralyzed. Anyway, it's rudimentary in us and well developed in animals to provide for the lateral missing wall, bony wall of the orbit they have. They don't have a lateral wall of orbit, okay, because eyes on the sides. Okay, now we understood the action of the muscles. But this is totally different than testing them. When we talked about the action of the muscle, each muscle has 2 or 3 actions. Like, for example, elevation, adduction, and internal rotation. Okay? And all muscles are synchronized. They help and complement each other. But to test individual muscle, the principle is to bring it in a position and ask to do a movement that the only possible muscle or the major muscle responsible for the movement asked to do is that muscle. Okay, this is called the H test. It tests the muscle in the H-shaped manner. The rule is to bring if you want to test for the superior rectus, for example, you bring the eyeball, the axis of the eyeball aligned with the muscle you are testing, which is the superior rectus. So you must ask the patient to look lateral, abduct the eye. Notice that we are not using the muscle in this movement. We're using other muscles. But when we were talking about the action of muscles, all the actions are produced by one muscle. Now you got the idea that we will be testing, but we will have to use other muscles to test a specific muscle. In this example, the superior rectus, for example, we will ask the patient to bring the eye lateral for the longitudinal axis to be aligned with him. Now, in this position, the major muscle that will bring the eye up is the superior rectus. So if he was able to look up in the lateral position, this means that the superior rectus is working. Another muscle, if you want to test for the superior oblique, I asked you to forget about this part of the muscle. This one is the one we're talking about. So we have to bring the longitudinal axis of the globe with this axis. Means ask the patient to look medial. Okay? He's not using the muscle yet. He's using other muscles to look medial. But in this position, the major muscle that will make the patient look down in the adducted position is the superior oblique. So the superior oblique, if he was able to look medial and down, so the superior oblique is working. Now you got it, okay? This is a drawing represents the actions of muscles, and this represents the results you will get when testing the muscles. See, the upper and lower ones are different now, okay? The inferior obliques left their places and the superior rectus came across, and the superior rectus, now you're asking the patient to look lateral and up instead of the action you know about the muscle, which is up and medial. Okay, now you got it. Now you know why. Because in this movement we are using other muscles and we're putting the muscle in position that in this position it's the major muscle that will produce the movement. Okay, you understand the basics of the H test now. This is the test result and these are the actions results. Okay, I hope you got it, and you will. It's easy. Now for the blood supply, the vessels, of course it's the ophthalmic artery. Ophthalmic artery coming out of the internal carotid artery and goes in the optic canal infralateral to the optic nerve, and then when it enters the orbit, see, it curves medially from lateral to medial, curves over the nerve. All these are multiple choice questions. Curves from lateral to medial above the nerve, above the optic nerve, okay, and gives all its branches. Now branches are many, muscular branches, of course. There are branches called the long and short ciliary. Ciliary means they are going to the eyeball to supply internal structures in the eyeball. This is one of the long ciliary arteries. See, it goes to the eyeball, enters around the optic nerve and supplies internal structures. Short ciliary, they are short, and they are branches from the muscular branches as well, and pierce the eyeball. You have a supraorbital and supratrochlear branches that goes to the outside, and the central artery of the retina. It's given by the ophthalmic artery. It's a delicate artery that pierces the optic nerve and runs inside the optic nerve and supplies the retina from the inside. It's a delicate. Imagine your vision is hanging on this delicate artery, the central artery of the retina that supplies the retina from the inside. We have anterior and ethmoidal arteries. This is the anterior ethmoidal, this is the posterior ethmoidal, and by now you should know the story of the anterior and posterior ethmoidal vessels and nerves, since we studied the nose and paranasal air sinuses. Now the veins are the superior inferior ophthalmic veins. The superior ophthalmic vein forms by anastomosis between angular and supratrochlear from the outside, enters the eyeball and drains all the corresponding branches, and exits to the cavernous sinus, drains into the cavernous sinus. The inferior one forms at the lower orbital margin and drains into the superior one and has a connection with the, remember, with the pterygoid venous plexus through the inferior orbital fissure. Okay. Now the innervation of the orbit, nerves in the orbit, I mean. First one is the optic nerve. The optic nerve is the fibers converging from the photoreceptors in the retina, the rods and cones, and exits the globe. See, at this site, the site of exit of the optic nerve from the globe is called, when you look at it from the inside, it's called papilla, or papillae, or the optic disc. Okay. The optic nerve is considered a tract, not a nerve. It's a tract from the brain that bulged, moved forward, and took the white matter with it, which is the optic nerve. Okay, and the proof to that is that the optic nerve is covered by meninges, covered by dura and arachnoid and pia matters. Actually, the layers, the coats of the eye or of the globe are derivatives of the dura and arachnoid and pia. The sclera, for example, is continuation of the dura, sclera and cornea. Okay? So since it's covered with meninges, means that there's CSF around the optic nerve. So the CSF will reflect the changes in pressure inside. So if there is increased pressure in the CSF, will be reflected on the optic disc that will bulge to the inside. This is called papilledema. When we are looking through an ophthalmoscope, you detected papilledema, means protrusion of the optic disc. This means that something wrong with the pressure of the CSF inside the cranial cavity. Okay? It has to be longer than the distance between the optic foramen and the globe to give a slack for the eye to move, not to be as tight as the same distance. The eye won't be able to move then. So you will see an S-shaped figure in X-rays. This S-shaped figure is the optic nerve. It's not straight like that. It takes an S-shaped figure in the X-rays. Okay? So this is about the optic nerve. The oculomotor nerve, number 3, cranial nerve number 3, it emerges from between the pons and midbrain and goes through the cavernous sinus. The cavernous sinus should be here in this area, including, it has the internal carotid and these nerves inside it, but it's dissected here. The oculomotor nerve, before reaching the superior orbital fissure, divides into superior and inferior divisions. This is the superior division, see? superior division supplying the levator palpebrae superioris and supplying the superior rectus, while the inferior division that goes deep, it supplies all the rest of the muscles except for the lateral rectus, because it's supplied from the abducent nerve. Now the branch from the inferior division that will go to the medial rectus will cross beneath the optic nerve. So now you learn the structure that crosses above the optic nerve, which is the ophthalmic artery, and below the optic nerve is the nerve to medial rectus. Okay? That's one more thing for multiple choice questions. Another question regarding the ciliary ganglion. See this ciliary ganglion? It hangs down from which branch of the inferior division? From the nerve to inferior oblique. The nerve going to inferior oblique also carries the preganglionic parasympathetic fibers to the ciliary ganglion, which is the ganglion of the orbit and belongs to the oculomotor nerve. And postganglionic fibers, called the short ciliary nerves, will arise and pierce the globe and supply structures inside, like the ciliary muscle and the constrictor pupillary muscle. Constrictor pupillae and ciliary muscles inside the eye. Remember, the dilator pupillae takes from the sympathetic, but the constrictor pupillae and the ciliary muscle take parasympathetic. You will understand this in the accommodation reflex. The trochlear nerve, this is the trochlear nerve. It's the only nerve that emerges from the posterior aspect of the midbrain, of the brainstem, then comes forward, passes through the cavernous sinus as well in the lateral wall, okay, and through the superior orbital fissure. But I forgot to tell you, the oculomotor passed inside the cone of muscles. This is another area of questioning. Which nerves, which structures are inside the cone of muscles? The oculomotor is inside the cone of muscles, means it passed through the common tendinous ring origin. But the trochlear, as you can see here, did not pass through the ring, so it's not inside the cone of muscles. You can see it's superficial, high up there, going to supply the superior oblique muscle. This is the trochlear nerve. Remember, it's outside the cone of muscles, and it supplies a sole muscle in the orbit, which is the superior oblique. So you have two muscles with a nerve, a complete nerve only for them, the superior oblique, the trochlear, and the lateral rectus, the abducens. And some tried to explain this as that these muscles are mainly used for the tuning of the movement of the eyeball. So they needed to be supplied individually. This is an opinion about why a muscle receives a whole cranial nerve just for it, like the lateral rectus and the superior oblique muscles, while the others take from the same nerve, which is the oculomotor nerve. This is something for you to think about. Okay? The abducent nerve comes from between the pons and medulla, from the front aspect, and passes an area called the clivus, which is at the back of the dorsum celli. I will show it to you in the cranial cavity, and then enters the cavernous sinus as well on the floor. It's lateral to the internal carotid artery and goes for its target, which is the lateral rectus, through the superior orbital fissure as well. See, this is the abducent nerve. It goes inside the common tendinous organ, so it's within the cone of muscles, within anything that will supply the muscles. These muscles that form the cone will be inside the cone because they are supplied from the global aspect, means the lateral rectus supplied from the medial surface. The medial rectus supplied from the lateral surface, the surface that faces the globe, okay? Other type of nerve fibers, the postganglionic sympathetic fibers. Now this time we're not talking deep petrosal. We're talking the same plexus around the internal carotid, but gave another branch in the cavernous sinus and went either to be distributed with the nerve called the nasociliary nerve, or by themselves go to the globe as long ciliary nerves. Both ways they will be called long ciliary nerves that will supply the dilator papillae muscle inside the eyeball. Now this will make us start with the story of the ophthalmic nerve. Ophthalmic is the smallest of the trigeminal nerve branches. It's the first branch. It's called V1, and enters the cavernous sinus, and before or at the superior orbital fissure it divides into lacrimal, see here, going to the lacrimal gland, frontal, and nasociliary. This is not the nasociliary, this is the trochlear. Nasociliary is the deep one, see, deep one. This is the nasociliary nerve. Lacrimal, frontal, and nasociliary. Now the lacrimal will go to supply the lacrimal gland and its capsule, and goes out, supplies the upper eyelid at the lateral side, of course. Remember, the lacrimal nerve joined by a communication from the zygomaticotemporal nerve that carries the parasympathetic to the gland, right? The frontal usually splits into supraorbital and supratrochlear. The supraorbital usually double branches that go from the supraorbital foramen, supplies the upper eyelid and conjunctiva, and supplies the scalp back to the vertex, while the supratrochlear goes above the trochlea of the superior oblique and supplies the lower part of the forehead and the upper eyelids sensation, okay, supratrochlear, through the supratrochlear foramen. Now, which nerves are inside the cone and which nerve is outside the cone? The lacrimal and frontal are outside the common tendinous ring, while the nasociliary went inside in the cone of muscles. See, this is the nasociliary nerve. Okay, now the nasociliary nerve will have to go to the medial side, so it crosses over from lateral to medial over the optic nerve with the ophthalmic artery, and splits to supply the anterior and posterior ethmoid nerves, and becomes the infratrochlear nerve that will go out and supply area of skin on the dorsal of nose and medial side of eye. Okay, this is regarding the branches of the ophthalmic. The lacrimal, we talked about it, to the gland and the upper eyelid and conjunctiva, and the frontal nerve, we talked about it, and its branches, the supratrochlear and supraorbital parts. See, lacrimal, frontal, supraorbitals actually, and supratrochlear, okay, nerves. This is the trochlear nerve, the fourth cranial nerve. The nasociliary nerve, well, I told you it supplies, gives posterior ethmoidal, anterior ethmoidal, and crosses from lateral to medial, superior to the optic nerve, okay, below the superior rectus, and it gives also the long ciliary nerves. I told you it's the sympathetics that came from the plexus around the internal carotid artery and ophthalmic artery, okay, when they join the nerve. Becomes infratrochlear and dorsal nasal, and in that way the ophthalmic nerve terminates, okay. The ciliary ganglion, now this is the parasympathetic ganglion of the orbit, belongs to the oculomotor nerve, and it hangs down from the nerve to inferior oblique. I said the parasympathetic fibers pick the branch going to the inferior oblique and then leave and synapse in the ganglia and in the ganglion, and the ganglion gives post-synaptic post-ganglionic ganglionic branches called the short ciliaries to go inside the eye and supply the ciliary body and the constrictor pupillae. This is regarding the parasympathetic root. The sympathetic root are the ones derived from the plexus, and they traverse the gland without synapsing as long ciliary nerves, and to be distributed also with the short ciliary nerves. And don't forget that the ophthalmic nerve is a sensory nerve, so it will receive sensation from the globe through the short ciliary nerves back to the ophthalmic nerve and back to the brainstem and the brain, the sensory route for the globe. And this is the basis of the corneal reflex, corneal sensation carried out by the sensory route of the sensory fibers of the ophthalmic nerve, okay, through the nasociliary nerve. Okay, now the last thing I'm going to inform you about is the reflexes. We have three reflexes in the eye: the pupillary reflex, which you get meiosis, constriction of the pupil with light. The afferent limb for this reflex was, the afferent limb, I mean by which is what took the afferent impulses directed to the CNS, which nerve? Of course, it's the optic nerve, because we are shining light here. And the efferent, who carries the fibers that will exert the action, the reflex action, is the oculomotor, because oculomotor carries the parasympathetic to the eye that's eventually going to supply the constrictor pupillary muscle, okay? The accommodation reflex is a combination of the pupillary reflex, because when you're looking at the close object, the amount of light radiating from that object is increased, and you need to do a meiosis, so that's a pupillary reflex, plus both eyes converge to the object, means both medial recti contract at the same time. Usually they contract alternating action for the eyes, both eyes to look in one direction, the same direction. But in this case, both eyes converged on the object. So both medial recti, there is a special part of the nucleus inside the brainstem for oculomotor for this reflex. This is called an accommodation reflex. So the afferent is optic and the efferent is oculomotor. The last one is the corneal reflex, which you try to touch the lateral side of the cornea with a piece of gauze or cotton or something. You will get the blinking reflex. So the afferent was the nasociliary, and this time, because we're talking about touch, so it's carried by the ophthalmic nerve. And the efferent was in the form of blinking. Blinking means involvement of the facial nerve, supplying the facial muscles, including the orbicularis oculi muscle. Okay, it's easy, but it's crucial to know the afferent and efferent limb components of these reflexes. Well, that will be it for today, and thank you very much for watching.